Good morning, everybody, and welcome to our Monday morning of Bio 201. We are going to be finishing off that one thing, peripheral nervous system. I had to switch gears because I'm in the middle of writing my test for 202, so I had that on the brain just now. If we look at the new syllabus schedule, I guess, I talked about, I don't know, I can't remember now if I talked about this on Friday or not, but we're going to move the test up. Not really. I mean, what it means is I'm just not going to lecture about the test on Wednesday, about peripheral nervous system on Wednesday. The test will be open starting the 22nd, and I'll put an announcement in on the 22nd. I'm looking at my calendar. 22nd until Saturday the 25th. So you have several days to fit that into your schedule. So test number 5 on the CNS and the PNS will be April 22nd to 25th. Okay, so that's that. And then on Wednesday, we will start the ANS and then get that done so that we can fit in that last test and the final. So okay, and then tomorrow we can do some Kahoot for Wednesday through Saturday's test, and then we'll do census tomorrow in lab, and then we'll have lab practical that's due the 28th, and there it is. So, God, I guess we've got that figured out. I don't even know. It's so ugly. Okay, because they stole that week from us. But anyway, okay, so we're going to start with the cranial nerves, the functions of the cranial nerves. I posted, let me see if I can find that. So if you haven't been into, there it is. If you haven't been into the announcements, let me go there right now in our class. And so I apologize that it's handwritten, but you know what? We would have been writing it by hand in lab when we were putting it together. So anyway, so here are the cranial nerves. And you know what, guys? I'm just going to go ahead and go off of this right now, and then we'll come back and take a look at our notes. Okay, so there are 12 cranial nerves. Oftentimes, as you saw in the video of the subdural hematoma, that it just said cranial nerve 3. It didn't say it was the ocular motor. So oftentimes we do just designate the cranial nerves with their Roman numeral. So you need to know that they come in this order. Okay, so they're not just whatever order, they are specifically this order, because this is the order that they come off of the brain. And we'll take a look at that again in just a few minutes. All right, so it's lots of times it's nice to come up with a mnemonic device, some way of remembering the order in which things go, like the classification of life with Kingdom, Phylum, Class, Order, Family, Genus, Species. So I don't have a problem remembering that, but I remember a long time ago, sometime in my life, that I remembered King Philip climbed over Fat Granny's sofa. So apparently that is easier for some people than just straight up remembering Kingdom, Phylum, Class, Order, Family, Genus, Species. But oh well, yeah. And then we learned the one for the, I forgot that we learned the one for the carpal bone. So you guys know what mnemonic devices are. Why am I doing this? Okay, so so here's the mnemonic device for the cranial nerves. Now, the one I learned said, on old Olympus's towering top, a Finn and German viewed a hawk. But that doesn't work today, because they took the 8th cranial nerve that used to be the acoustic nerve, and they turned it, or they changed it into vestibulocochlear, because that's a little more accurate, because acoustic just said that that was for hearing, but it's for hearing and balance. So instead of saying it's hearing and balance, what they did was take the two places within the ear that it goes to, the vestibule and the cochlea, and then turn the nerve into the vestibule, rename the nerve the vestibule cochlear. So I opened it up to my students one year, and I said, if anybody wants to get some extra credit, I'll let you come up with a new mnemonic device. And so this is one that one of my students came up with, and I really liked it. So she kept the first 5. So on old Olympus's towering top, and then she changed, Achilles faced vicious giants, victory awaited him. So if you need to remember an order, you can remember that. Whatever you want to do, I don't really care. So, but what I've done is given each nerve its cranial nerve, its Roman numeral designation, and then the name of it. And then if it's a sensory only, remember nerves can be sensory, motor, and both. So I made a little key down here at the bottom, sensory only, motor only, and both. And there's also a mnemonic device that goes, some say marry money, but my brother says it's bad business to marry money. And I think there's one in your lab manual too. So anyway, whatever you need to do to learn these is whatever you can do. So now I'm just going to go through them and explain the functions of the cranial nerves, and then we'll go on from there. All right, so first cranial nerve is the olfactory nerve. It's sensory only, and it's for smell. So it goes out to our nose, and it just goes into our nasal epithelium, down through the cribriform plate, and up into the very, very most superior portion of the nasal cavity. Cranial nerve 2 is the optic nerve. It's going to go from your eyeball back to the occipital lobe for vision. Cranial nerve 3 is the ocular motor. It's motor only. There are 6 eye muscles that move your extrinsic eye muscles that move your eye. 4 out of those 6 muscles are controlled by the ocular motor nerve. And then remember the lady that had the subdural hematoma, her pupil was fixed and dilated because the muscles within the iris are also controlled by the ocular motor. So they could not reflexively adjust to light because of the paresis that was there in the ocular motor nerve. So 4 out of the 6, you don't need to know which ones, you just need to know that 4 out of the 6 are innervated by the ocular motor. Cranial nerve 4 is the trochlear. It's movement only or motor only, and it is one of the 6 eye muscles, superior oblique. Again, you don't need to know that, but this is superior rectus, inferior rectus, lateral rectus, inferior oblique, and anyway, just so you know, there's names. Okay, cranial nerve number 5 is the trigeminal, and it is both. It has a sensory component, which goes to your eye, your upper jaw, and your lower jaw for touch. So if you have to go to the dentist and have your teeth worked on, then we have to numb the maxilla and we have to numb the mandible in order to do your teeth. So those portions, those branches of the trigeminal, we just call them V1, V2, V3 because of the 5, the cranial nerve, the Roman numeral V is 5. So those are the branches. So those are the sensations. So all of the touch to your face is all because of the trigeminal nerve. The motor component of the trigeminal nerve is to move your muscles of mastication. So the masseter, the pterygoids, the up on your head, the temporalis, those are the muscles that would be innervated by the motor portion of the trigeminal nerve. Cranial nerve number 6 is the Achilles. No, it's not. It's the abducens. Sorry, it's motor only, and it'll go to it goes to lateral rectus, lateral rectus. This is medial rectus in here. So lateral rectus is the abducens. It's what makes you go cross-eyed. So anyway, then we have the, it looks down and out. It abducts, it turns your eyes to the side. That's what it does. And you can't contract both abducens, or you can't fire both abducens muscles at the same time because our eyeballs track together, so you can't look out to the sides of you at the same time. You have to look one direction or the other. That's abduction. That's why we call it the abducens. Okay, cranial nerve number 7 is the facial nerve. It is both sensory and motor. The sensory component goes to your tongue for the sense of taste in the front of your tongue, about the anterior 2/3 of your tongue, because that's how your tongue forms. Embryonically, when your tongue forms, the 2/3, the front 2/3 forms one way and the back third forms another way, and then they come together and meet. at that 2/3, 1/3 boundary in the back of your throat, back of your mouth. The motor is all the facial nerves. So contraction of all the facial muscles. I mean, and so when you have Bell's palsy, then it's the facial nerve that's been affected and is not stimulating. It's been paralyzed by a virus, by stress, by trauma, lots of different causes for Bell's palsy. But your muscles are, there is no tone in your facial muscles at all, and they just sag, and then you can't voluntarily contract them. Okay, cranial nerve number 8 is the vestibulocochlear nerve. It's sensory only. It is for hearing and balance in your inner ear. Cranial nerve 9 is the glossopharyngeal nerve. It's both. The sensory is for taste in the back of your tongue and the back of your throat. You do have some taste buds back there, so you can taste really bitter stuff. And the motor is the gag reflex. So when you swallow, the glossopharyngeal nerve is stimulating those pharyngeal muscles to get you to swallow. Cranial nerve 10, oh yeah, cranial nerve 10 is the vagus nerve. This is the longest nerve that you have of the cranial nerves. It's the only one that does not, no, I shouldn't say that. It's one of 2 that doesn't affect your head, and it goes internally. It's the only one that goes down into your internal body cavities. When it's sensory, it's to let you feel. It's your visceral input. So when you feel nauseous, when you have a stomach ache, when you have indigestion, those kinds of things, that's all the vagus nerve. If you're having a heart attack, your vagus nerve is bringing that input in. And then the motor is involuntary. So there's no voluntary skeletal muscle that it goes to. It's just parasympathetic output to your cardiac muscles, your smooth muscles of the cardiovascular, that's what CV stands for, and gastrointestinal tracts. Cranial nerve number 11 is the accessory. It's motor only. It goes to the trapezius and levator scapulae to shrug your shoulders. And cranial nerve number 12 is the hypoglossal, and it's for sticking out your tongue. And so there's the left hypoglossal nerve makes your tongue stick out to the right, and your right hypoglossal nerve makes your tongue stick out to the left. And so when you contract, or when you fire both hypoglossal nerves together, then your tongue sticks out straight. So there are the functions of the cranial nerves. So if we go to our notes, oops, let me get out of that. Where's my PowerPoint? Okay, so all right, so when we go to my PowerPoint, let's make sure that's what we're actually, okay, yep, that's what we're sharing. All right, so when we suspect that we have a head injury or some other nervous system damage, then we'll do what are known as tests for dysfunction. And typically we'll do this when an individual might have suffered a concussion. So that my sports medicine people are very familiar with these tests for dysfunction. Because they get a guy out on the football field and he's laying on the ground, and then he gets up and they bring him off the field, and then they're going to check to see is there any cranial nerve dysfunction. So here are the things that will be wrong if the person has had damage to one or more of these cranial nerves. So these are, like I said, tests for dysfunction, and then this is where it goes. And then here you can look at, we'll just go through this again. So here's 1, olfactory, 2, optic, 3, ocular motor, 4, trochlear, 5, trigeminal, 6, abducens, 7, facial. I don't like this picture because they didn't do that very good. 7, facial, 8, glossopharyngeal, 8, vestibulocochlear, 9, glossopharyngeal, 10 is the vagus, is this big one, 11 is the accessory, and then 12 is the hypoglossal, that's up here. Okay, and then you can go through all of these little pictures, and I'll tell you all about that. Okay, we did this in lab. We were talking about plexuses and how the nerves come out of the spinal cord. In the neck region, in the arm region, in the lumbar and sacral region, we have plexuses, but we do not have a plexus in the thoracic region because those nerves are going to come out, and gee, there's 12 of them. So maybe where are they running? They run along on the ribs when they come out, and then innervate the anterior portion, in the back too, but the anterior portion of your trunk. All right, so if we take a look at this, there are 31 pairs of mixed nerves. They are sensory and motor, both. So there's a plexus, cervical, brachial, lumbar, and sacral where the roots. So remember, we have dorsal roots and ventral roots. So they're going to come out and then interconnect. Their little straight pieces called rami are going to interconnect with one another and then become the nerves of the body. Dermatomes. Okay, so dermatomes are super cool, you guys. Areas of skin innervated by a continuous branch of a single spinal nerve important in shingles. What the heck does that mean? Okay, well, there's more than just this. Well, okay. So when you develop as an embryo, running down your back, you have a bunch of nervous tissue, obviously. And so what's going to happen is that nervous tissue is going to extend out from your spinal cord, and then it's going to innervate. So we just have nerves that come out in straight lines off of the tissue, the tissue that's there in the back in the embryo. And then it's going to feed out into each one of these areas. And then also the muscles and bone that are out here will also develop from these somites, is what they're called, these little bundles of tissue that run along your spinal cord as an embryo. So each somite has a bone part and a muscle part and a nervous part or skin part. And so the dermatomes are the nerve endings that go to your skin. So if I were to touch you or make you move the back of your head, the muscles in the back of your head, you would use cervical nerve number 2, or you would feel it through cervical nerve number 2. And then all of this part of your body, C4 is up here in the back, and then it comes around to the front, C5, and then C6. Oh, look at that. C5 runs down your arm too, C6, C7, C8, because remember, those are nerves that make the brachial plexus. So not only do they come from your neck region, but then they're going to run down your arm as well because of the plexus. Now notice with the thoracics, they're just right here. They don't go out anywhere else in your body except for T2, or is that T1? T1 is, oh, because that's part of the brachial plexus. That's the last one. So C4, 5, 6, 7, 8, and T1 are all brachial plexus. And so they're going to go here out into your arm. But then the rest of them are just going to stay in your trunk. And then the L's, you can see when your legs form, they twist in from the little paddles that you used to be as an embryo. So that's why the nerves are twisting here in your leg. And then the S's, the sacral nerves, those are going to run down back of your leg. Okay. Now, here's what's important about your dermatomes, okay, these different sections. If you had a neck injury, for example, so let's say that you damaged C5. Well, I might not be able to get you into the CT scanner to see the extent of damage in C5, but what if I poked you right here? I might not be able to feel it, and you might not be able to move your back of your arm. Okay, so, or the side of your arm. And so that would indicate to us where there's some nerve damage, spinal cord nerve damage. We also can use these dermatomes to let us know how spinal anesthesia is working. So let's say that you're having a baby, you're having a C-section. Okay, so here's my story. I was having a C-section, my last C-section, and I had to have a C-section. Okay, so I'm having my last baby and I'm having a C-section. And so what they did was put the anesthesia. So we're gonna poke in between L4 and L5. So we're gonna anesthetize you right there. Okay, and this is not the bad one where I got the spinal headache. This is the pregnancy after that one, 5 years after that one. And so what they're hoping is that all of this tissue, obviously, right in here is numb so that they can cut me open and I can have my baby. So, and that anesthesia should just flow through all of this area right here. All right, so what they do to make sure that it's time to deliver your baby, that your anesthesia has, you know, like when you go to the dentist and they make sure that you're numb. So how can we make sure that you're numb? Well, we touch you in the various dermatomes. So we touch, touch, touch right here and all these. And they say, can you feel that? Can you feel that? Can you feel that? So I had felt some, and so we waited a few more minutes, and then they did it again, and then we said, okay, I can't feel that anymore. And so they said, all right, let's go ahead and deliver her baby. Well, they get me all laid out on the table, and then they start to cut. And so they cut right, well, actually they cut kind of right through here. And I did not feel that. I didn't feel anything in my skin. But remember that these nerves are not going to go just to your skin, but they're going to go all to the muscle in your abdominal region as well. So then they started to cut under my skin, into my abdominal wall, into my uterus, and they started to pull this open so that they could get my baby out. Because once they make that incision, then they don't keep cutting, they just kind of pull your tissue away, you know, because all the connective tissue just kind of tears away from itself, like the epimysium and stuff. Okay, that hurt so bad that all I could do was cry. I couldn't even tell everybody around me that I could feel everything that they were doing. And so the anesthesiologist was up here by my head, and he goes, oh my goodness, her heart rate keeps racing, keeps going up. And so he says, I've got to put her under. So they put the little mask on me, and boom, I was out. Because my doctors down here, once you make that first incision, you got to get that baby out of there. You can't just mess around. So the anesthesiologist was in charge of me, and the doctors were in charge of my baby. And so as soon as he put the mask on, I was out cold. I didn't have any idea that my baby was born. I didn't have any idea that they were sewing me up. I was crying when I was just crying the most I swear I've ever cried in my life because of pain. And so I went under crying. I came out in recovery. When I came to and realized, you know, that I was awake, I was crying, and the nurses in there, and they said, well, what's wrong? And I said, I don't know what just happened to me. And so they wheeled me into my room, and there was my husband was holding our baby, and I'm like, what is that? Because there was no connection between me being pregnant and that infant that my husband was holding in his arms. And it was the weirdest feeling ever, because with my other 2 C-sections, I was awake, the anesthesia worked the way it was supposed to. And so, you know, I made that connection between, oh, you know, here is this baby that's coming out of me, and then it's my child. Yes, I did deliver my baby here in the Gila Valley, but that was 17 years ago. So know that it's better. Don't worry. And it was an anesthesiologist from Tucson. It wasn't any of our nurse anesthetists here, because we didn't have any back then. So no worries, but yeah, it was here. Okay, so what about the shingles part? Because it says they're important in shingles. So here's the deal. For those of you that have had chickenpox, when you get the chickenpox, you know, the virus gets all in your epidermis, all over your body. And when I got the chickenpox, I was 23, and I was my first year teaching high school, and I got them from my students. I mean, I had, it was the worst case of chickenpox I've ever seen. And so here's what happens when you get the chickenpox. So we'll get the pox in different dermatomes of your skin. And then once you get better, the virus never leaves you. So let's say that you had some pox in T7 dermatome. So it's going to go back here because you have a sensory nerve that's going to go back to your spine. So here's my sensory nerve. So there it was. This one would be right here. So this sensory nerve would go back here, and then would become my dorsal root ganglion of my T7 spinal nerve. And that's where the virus hangs out in you for the rest of your life. You can never get rid of it. And it becomes incorporated in your own DNA, and it just hides. So you may have some virus hiding there and there and maybe there. And so that's why when people get shingles, that the rashes come in lines like this, in sections, because it's a virus in each one of these dermatomes. They don't merge between dermatomes. One virus comes out in one dermatome, and another here, and another here, and another here. And so that's what shingles looks like. So if you have not had the chickenpox vaccine, friends, go get the chickenpox vaccine, because you never want to be my age. You don't want to be 23 or older getting the chickenpox, because it is the most miserable thing ever, ever, ever. Okay. All right, so let's move on. Okay, so those are dermatomes. We're not going to worry about this. Oh, yes, we are, because we're going to talk about reflexes. So what is a reflex? Well, it's something that does not involve the brain at all. So what happens is that the sensory input comes in, it just goes through your spinal cord. See, that's the spinal cord right there, and then comes right back out, and you're not conscious of it. And here's how you know that it happens, and I'll show you what happened. Okay, so we get sensory input, it comes in, goes into our spinal cord, but it can also go through a sensory neuron, and then it can go up here, okay, even up higher than cerebellum and basal nuclei. We can go up here into the cerebrum, be aware, and then we send the signals back out. And then it becomes motor output. But if we are doing simply a reflex, sensory input comes in, goes to the spinal cord, synapses with a motor neuron or with an interneuron, and then synapses and goes right back out. So we're going to take a look at then what are reflexes and how they work. Okay, so remember the three parts of the reflex arc from lab. So the receptor, sensory neuron, spinal cord, or the integration center. So spinal cord or interneuron, motor neuron, and effector. So there is the integration center. It's going to be at the level of the spinal cord. We may have a motor neuron, or we may not need one. We may have this sensory neuron synapsing directly with this motor neuron. All right, so what is a reflex? It's a rapid, predictable motor response to a stimulus. Why is it predictable? Because I know if I touch you in this place that you're going to do this thing, because they're all wired together. So that sensory input is wired, hot wired into that motor output. And that's why we test your reflexes, because we want to make sure that that wiring is right and that your spinal cord is functioning properly. If we were on campus in lab, we would have done the reflex lab, and it's fun, and I'm sorry that we don't get to do it. But our reflexes are inborn, involuntary, and intrinsic, or they may be learned, but they're still involuntary. They still just go to the level of the spinal cord, because we got to figure out how to contract that muscle, because babies don't know how to walk. But once we learn how to walk, do we think about keeping our balance when we fall? No. Okay, so that's the difference. Many spinal reflexes occur without the involvement of higher brain centers. I have a little video. I think I'm just going to post that in the announcements, the cerebrate frog. So what they did, this is like run around with the chicken with its head cut off. So they cut the head off of a live frog, and then you can see how the spinal reflexes work as long as the spinal cord is intact. So I'll probably watch this with you, but post it in a separate thing, not right now. Okay, so muscle spindles then are receptors in skeletal muscle sensitive to stretch. So these are our proprioceptors. It helps maintain our muscle tone and posture so we don't fall down. Think about when you fall asleep. Okay, so let's say you're sitting in my class and you start to fall asleep and you're not consciously contracting the muscles in your neck. So what does your head do? It's a heavy thing. If you're not consciously contracting them, then your head is going to start to fall. Well, that's going to stretch the muscle spindles in the muscles in the back of your neck. Go to your spinal cord and contract the muscles in the back of your neck so you pull your head back up again. Okay, so that's how those work, and we'll take a look at what they look like in a minute. Actually, we're going to do it right now. Okay, so here are the muscle spindles. So we have sensory neurons. So we've got two kinds of sensory neurons right here to detect the stretch that's going on in the muscle. And typically muscle spindles are deep within a muscle. Now we're going to send that sensory input back to the brain. Okay, and then we're going to bring motor output out to contract those muscles to help maintain muscle tone. And then we're going to do that. We're going to have many muscle spindles throughout our muscles. And then we'll just alternate through them in order to keep the muscles contracted properly. It also lets us know how much stretch is going on so that we don't over contract a muscle or we don't over relax a muscle. And so it's protective in that manner as well. But we're not aware of it. I mean, you got muscle spindles firing all the time right now and you don't even know. The second reflex structure, I was trying to think what was, is this receptor called the Golgi tendon organ. And so what the Golgi tendon organ is gonna be obviously embedded within a tendon, and it's gonna also sense the amount of stretch that's going on within a muscle, within a tendon, within a joint, to make sure that you don't damage the joint, you don't do too much pulling or contracting or whatever. So Golgi tendon organs, then receptors in tendons help protect muscles and tendons from stretching and tearing and ensuring smooth onset and termination of muscle contraction. So they're going to work together so that you don't walk all jerky and weird, that you're just fine. All right, now this one is the one that you are the most familiar with, is the flexor reflex or our withdrawal reflex. Now it's interesting the way, actually I got lots of pictures. Let's look at this one. It's interesting how our muscles are designed in our limbs so that if we ever have any damaging stimuli, that as our muscles contract, we pull away from the damaging stimulus. So I don't have a one for touching a hot stove, but let's just say that this person, instead of someone grabbing you, that they touched a hot stove. So they touch that. Now, what do you want to do? Do you want to keep touching the stove? No, I want to pull my hand away. Well, what does pulling my hand away entail? Flexion of my elbow. So my elbow flexor is my biceps brachii. So the heat of the, pain, heat, temperature, whatever, stimulus is going to go up the sensory neurons here, go and synapse in my spinal cord with my interneurons, so that I can contract my biceps and relax my triceps brachii so that I can flex my arm. Okay, so that's going to be just a regular withdrawal reflex. Same thing if I stepped on something sharp, what am I going to do? I'm going to contract my my hamstrings here so that I pull my foot away from that damaging thing. Casey wanted to know, if you get hit with a patellar hammer, what's going on there? It's what that does is produce just a slight stretch in that tendon so that you get a slight stretch in the muscle spindle, which will then go up here and down here. And so to protect this from stretching too much, what do I want to do? I want to kick out. And so there's the motor output to kicking out. Let's see. Okay. So there's the flexor reflex. Now, crossed extensor. So this is what they're trying to do in a crossed extensor, but this is really weird because I wouldn't do this. That if you flex, so let's say somebody grabbed my right arm and I wanted to get away from that person grabbing my right arm. I'd flex. Sure, we do that. We know that. But then that stimulus apparently is supposed to go over to the other side of your spinal cord to cause your left arm to extend. Well, I don't really ever remember if someone grabs my arm, I just pull it away. I don't reach out to like punch the person or push him away or anything. So I think this is weird, but here is a perfect example of a crossed extensor. So I'm going to draw a little picture. It's going to look lame, but I don't care. All right, so let's do crossed extensor though with your leg. So here is my right leg. Here's my, oh, that's not a toe. Okay, so there's my big toe and my foot, and I'm gonna step on something sharp, jaggedy glass. Okay, ow. What am I gonna do? Well, I'm gonna flex my knee, right? To pull my foot away from the sharp object that I just stepped on. But if I flex my knee on my right side, what do I have to do over here on my right? On my left. So, okay, I'm going to flex on my right. This is right. What am I going to do on my left so I don't fall down? Yeah, I'm going to, oh, that's a weird looking foot. It's like 1, 2, 3, 4, 5. I had to make sure I didn't have too many me toes on there. I'm going to extend out this way on my left side so I don't fall down, right? So I withdraw on this side, my flexor reflex, withdraw. So this is flexion here. And then I'm going to extend my lower leg, but I'm going to extend on the other side. So how did that happen? Well, that sensory input came in, synapsed with this motor neuron that, this interneuron, look what it did. It went over here to the other side of the gray matter to other interneurons here that then sent the motor output to your leg muscles that made you stand on the leg that wasn't hurt. So this is called the ipsilateral side, ipsilateral, same side, lateral. As the stimulus, this is contralateral. This is against the side. So it's the opposite, it's contralateral. I know that looks horrid, but let's look at the notes. Where is it? Oh, here it is. Okay, so crossed extensor, maintaining balance when stepping on a glass or sharp object. Withdrawal on the ipsilateral side. So this is the side with the stimulus. This is a sharp object. Extension on the other side so that you don't fall down. So really important you get crossed extensor. All right, and then the last kind of reflex is not really a reflex, but it's how do we tell an abnormal reflex. So we have something called Babinski's sign. This would let us know if we have any cortex or nerve damage going up in our CNS. Okay, so let's say that, so let's get into another dumb picture that I can't draw, but whatevs. Oh, there it is. Okay, we'll do pink this time. Okay, so here is the sole of your foot. Is that enough toes? 1, 2, 3, 4, 5. Okay, there we go. So this is the sole of your foot. And you've probably seen this maybe on Grey's Anatomy or ER back in the day, or I don't know, some medical show. They get a patient come in, patient's unconscious, and then they take and run a pen or a tongue depressor or something up the sole of somebody's foot. So plantar surface is plantar surface. Okay, now, oops. Now, normally your toes will curl and you'll do withdrawal. You'll just flex and pull everything away from that ticklish feeling. Now, because babies don't have a well-developed cerebrum connection, they're still pretty reflexive. They don't have a lot of conscious thing. They get the primitive response where your abnormal response is dorsiflexion. Okay, so you pull your foot back and your toes fan out. So instead of curling up like you're trying to make a fist out of your toes, what happened with the plantar, normal plantar flexion, you get dorsiflexion and your toes fan out. So babies will do this, newborn babies will do this, but if you are an adult and you have Babinski's sign, that's this abnormal thing, then we know, even though you are unconscious, we know that you have some cortex damage. Where did I put that? Cortex damage right there. Okay, so we can quickly assess without putting it in a CT. We can go, oh, okay, we know that that person's had a head injury. We see some cerebral cortex damage. We got to treat them as, you know, do a whole different kind of thing than we might have done. Okay, so you don't want to have Babinski's sign in you, because then that means you've got some brain damage going on. Okay, so that is it for, actually, let me get rid of this first. For the reflex stuff, so let me just go through the rest of these pictures and see. Oh, okay, so now what I want to make sure that you understand, how is it that I can feel it, even though it's a reflex, I can still feel it. So let me draw something in here. This will be a little better than my stupid drawing so far. Okay, so here comes my sensory input in. Then I'm going to synapse with another sensory neuron that's going to take my information. Oh, look, where is it taking it to? To my brain, through my thalamus, limbic system structures, the reticular formation, all of that the pain's going to go up into there, so, and then on up into my parietal lobe, so that I know what's going on. But I also have sensory neurons. I mean, other interneuron. Ooh, I should make that green. Hang on. Okay, so I'm going to have some interneurons here that are going to go like this, and then a motor neuron that's going to go right here, actually closer in, and then go out like that, so that I can pull my hand away, but yet I still know that I touched a hot stove. But I already start to pull my hand away before I touch a hot stove. Now, here's the other thing is, look at this, serotonin or norepinephrine releasing fibers, okay, may even be an endorphin. And so this is going to come down to inhibit this so that I don't feel pain anymore. So I'm not sending. So this is not happening. And so that's a lot of times, you know, if you got a runner's high, or you're so involved in taking care of whatever caused the pain that you don't realize that it hurts until you stop. And then you look down and your arm's hanging off and you're like, oh my gosh, that hurts. It's not that. You're not going to be that subtle about it. But that's why we pull away at the same time, even before we feel it. And then we can also inhibit the pain if we need to by this motor output coming down here and releasing calphins and endorphins and stuff. Okay, so that will do it for, yep. Okay. That'll do it for what's on this next test. So let me really quickly go back here. Oh, let me get rid of this. Okay, so what do we always do so that we know what's going to be on the test? So go through, sorry, just trying to figure out what I need to do. Okay, so in the peripheral nervous system notes, in the peripheral nervous system notes, make sure you go back and look at all of the objectives, okay? And then go back to, just a minute, to your cranial nerve notes, which I don't know where they are. Hang on. I mean, not your cranial nerve, but your central nervous system notes in chapter 12. And go through this. Okay, so go through these objectives and make sure that you know all of the functions of those things as well. Okay, so other than that, I don't have anything else for you. Tomorrow in lab, we're going to do the senses, and then we can Kahoot too for the test this week. Hey, so does anybody have any questions? Oh my gosh, people in my group chat. It's all of us instructors, all of us professors. So if nobody has any questions then, and sure, we can talk about stuff tomorrow if you think about something while you're studying. So, okay, if not, well, I'm going to end this and get this posted and hope that you have the good rest